Hi, I'm Naomi Murphy, and this is the Locked Up Living podcast, where we talk with a wide range of people about harsh aspects of institutional life.
We also explore some of the ways to overcome them and to grow and develop. I'm David Jones. So join us every Wednesday morning, 6 o'clock UK time, for a fresh podcast.
So today we're joined by Esther Cole, who's an author, podcast host, consultant clinical psychologist and founder of a multi-award-winning company, Lifespan Psychology, the diverse practice, and also wellness boss coach, boss standing for business owner support squad. She's co-editor of Psychological Therapy for Paediatric Acquired Brain Injury, Innovations for Children, Young People and Families, and she's honoured to be the first Black clinical psychologist to achieve the Early Career Award in 2020 from the BPS for her role initiating and editing this book. Glad you could join us today, Esther. Welcome.
Thank you so much for having me on the show. I've been really looking forward to this.
Hello Esther, very nice to meet you. So shall we begin with you telling us a bit about the theme of your podcast, which is called Breaking Through Therapy, and who is it aimed at?
That's a really good question. Who is the target audience? Breaking Through Therapy is a show where people come with their former therapists to discuss the breakthroughs that they've made along their therapy journey. So the podcast was aimed at both sides of the fence, really. People who are looking for therapy or looking for self-help, guided self-help, but not really sure if it would work. And also people who deliver mainly talking therapy. We also have nutritionists and other types of therapists on the show as well. So I really wanted to demystify what happens in therapy, make it really transparent and make it really hopeful. And so, seeing lots of examples of post-traumatic growth, that people can come through adversity, come through the other side and thrive and build, transform their lives and transform their communities. And so we've had a range of clients come on the show, range of people talking around issues of trauma that they've experienced, sexual assault, addictions, violence, a whole host of things, really. A lot of adversity, but how they've come through and triumphed over those.
Thank you. So, that's a really unusual format, isn't it? Have you found it easy to persuade people, because we're talking really about therapists and their clients and their therapists? Have you found it easy to persuade people to come on?
It's tricky because obviously it's hard to get the format. There are lots of people who want to talk about, the brilliant work that they do as therapists. And there's lots of clients who are happy to come on the show. Lots of people happy to talk about their experience of adversity and how they can help others and how they've helped themselves to overcome that. But it's really hard to get both of them on the show together. But that's what I really wanted to do. That was the concept really, to see how that transformation, how that process happens, what happens in the therapeutic relationship. But it's really interesting just how people have responded to being anonymous. So some people were really quite happy that we don't show the video camera. We recommend they change their name and any of the people in their lives, the names of people in their lives, family and friends, and they don't reveal where they work and things like that. But some people really haven't responded well to that because they feel like we're hiding something, or there's some element of shame there, or that we are encouraging people to mask the truth, which is a real shame, really, because that's not what it's about. It's really about protecting them.
When you say some people, do you mean your guests, or do you mean
people
who are listening?
Yeah, it's a bit of both. So the people listening, so psychologists tend to be concerned that I have this format. They're concerned about the vulnerability and risk to the client of obviously having their lives broadcast in this way. So the psychologists are really concerned about the ethics sometimes, but then the clients are saying, no, I want to shout this from the rooftops, and I'm not ashamed, and I want to be bold and out there, and I don't want to hide my name. I think, it's tricky because sometimes people who have wanted to reveal their identities are quite relieved when we finish recording that actually, they went to places in that conversation they hadn't been for years, place in their mind, and really, really difficult experiences they've revisited, and actually they're quite happy to have remained anonymous by the end. So it's a tricky tightrope to walk, really, but we're sticking with anonymous clients at the moment.
That's really interesting, because I think people who've not had lots of visibility are talking about personal issues, you don't necessarily know how you're going to feel when, it's easy to think, oh, well, I'm quite comfortable talking about this, I'm an open person. But actually, that's quite different to having something available on the internet that's going to be there forever that people can listen to. We've had one conversation where somebody actually felt that they were very exposed by it, by telling their story in the future, and then we've removed the conversation because they felt exposed by it, not because they were ashamed of their history, but because future people that came into their lives had a problem with them being there so visible.
And that makes sense. And I think with social media and the internet, things can be taken out of context as well, and like clips can be used or replayed, and it could be used insensitively. And I think it's really just a safeguard against future risk, isn't it? Right now we feel a certain way, but let's just safeguard any future risk out there.
So, Esther, you mentioned ethics. So am I picking up correctly that you cope with the ethics question really by insisting that it's all anonymous?
Yes, I think, we've decided that, and through supervision as well, consultation with my own supervisor, that it would be the best at this time for them to remain anonymous.
Very interesting. So how did you think up the idea for this podcast? Is it anything about you?
Well, that's an interesting question. I think maybe before I ever had therapy myself, it would have been nice to have listened to what other people had gone through before taking that deep dive. And so the cover of the podcast is two people jumping out of an aeroplane and then me flying in the sky, because it can feel like free falling. It can feel like how can you trust a complete stranger with like the deepest, darkest, most difficult parts of yourself and your experiences, and also what other people have said and done. And there's always the legal context of therapy. It doesn't happen in a vacuum. There are safeguarding procedures and risk procedures, and there are things that therapists have to do where they might have to break confidentiality. Yeah, I feel like I'm going off tangent a little bit here.
Well, no, I was thinking how important it is actually for people to have a real sense of what happens in therapy, because we're too used to seeing what happens in the media and media's depiction. I'm just watching Department Q at the moment on Netflix, and the therapist there has got a very unconventional style.
I agree.
Yes, exactly. But I think anyone who's not had therapy might think that's a normal way for a therapist to behave, or the number of therapists that fall in love with their client.
Oh my goodness.
And without any sort of thinking about the ramifications and consequences or the ethics of that. So actually, I think there is something really useful about people being able to have more of an understanding of what is therapy like.
Yeah, the films and the media distort what it is that we do and how helpful it could be. Or there's only one example of I don't know what everyone listening is going to think, of a really incredible kind of Hollywood interpretation of a therapist, and that was in Ginny and Georgia. I don't know if you've watched that Netflix series, but it's incredible. So the mum is a serial killer. I'm sorry for the spoiler, but you probably already know if you're listening. And so, but the therapist in that show was absolutely incredible. Like, she was textbook brilliant, but also had that really authentic, warm, like you really felt that you felt the care, but the professionalism. You felt that she was highly trained and very skilled, but also navigating some really kind of treacherous and difficult situations between the mother and daughter. Just managing and negotiating boundaries and ethics really incredibly. And that was probably the best time. But in all my life, I hadn't really seen a very good depiction of what therapy is and what therapy can do. And the young person self-harming in that series. So it was just brilliant to see kind of what I had seen, that these techniques to reduce self-harming actually work. So yes, I do hope that people listening to the podcast will get something authentic and rich and meaningful from the lived experience of people on the show. And it just highlights some just amazing post-traumatic growth as well. And I don't think we, as a world, talk about post-traumatic growth enough. We normally talk about when things are going wrong, or when things are, mental health deficits and mental health problems and mental health issues. But what about post-traumatic growth? Why don't we study that a lot more when we're training? So that's what you'll see in all these episodes.
I think that's a really good point, because we tend to be very focused on victimhood and deficit of experience, don't we, rather than helping. I don't think there's enough emphasis in training on how you engage people in restorative practices, how you replenish, and I think, growing from adversity is an important part of that side of the equation, isn't it?
Yeah, absolutely. I mean, we've had some incredible life stories witnessed on the show. So one lady had almost died from complications with her bariatric surgery, which is where your stomach is stapled, I believe. She'd almost died. And surviving that left her with irreversible damage that meant that she could no longer eat solid food. And rather than, feeling suicidal or thinking that her life wasn't worth living, or not going out, or not ever working again, or whatever options she may have had, she actually turns this experience into being an incredible chef to help people with feeding difficulties. And it could be people who have feeding difficulties as a result of surgery, or who are very ill or end stages of life, or neurodiverse. But she turned that into an ability to make exquisite food that tasted great for people with limited, feeding options. And these are incredible stories that just are so inspiring. How do we turn that pain into something worthwhile for ourselves and for other people?
How easy do you find it to get the guests on your podcast to really focus in on that element of their story, whether it be the therapist or the client or the former client?
So what we do is there's a couple of forms. We're really good at psychologists, aren't we? Giving you a form. So there's a couple of forms to fill out before the show, and that really helps me sort of organise the conversation. And I think it goes back to that ethics as well, that people don't feel they're on the spot. So everything that they're happy to share, they put in that form. And then the forms are swapped with their therapist, their former therapist, and they can both take a look. And then I bring those narratives together, bring that journey together, and just see what the impact was, what impact they had on each other, and what they learned and what their experiences were. And that sort of guides the conversation. I hope I've answered your question.
Yeah, no, that's helpful. It sounds like you're kind of like priming them for those kind of questions anyway.
Yeah.
And as we're talking, I'm just reminded of, have you read the book by Bruce Feiler, Life is in the Transitions? Because that's all about post-traumatic growth, and he's a storyteller, and he interviewed hundreds of people about sort of adverse experiences they'd had across their life, like cancer, loss of a partner, and actually describes the kind of stages that people take to grow from and recover from, and these kind of horrible crises that we experience during life. But it's a fantastic book.
Thank you for that. I can't wait to read that.
So being a clinical psychologist can seem like a very privileged position to some of the marginalised groups that psychologists work with. Do clients ever ask you, what do you know of adversity?
Do you know, I'm looking at my notes because that is a tricky one. I've definitely felt an element of privilege in terms of like my education. I went to Oxford. I got an assisted place for private school. I wasn't from a kind of privileged background, from a single parent family, but education I think is a major privilege and opportunities. I wouldn't say that I've had so many people ask me, but I'm acutely aware, and I think it's very important for me to self-reflect and understand what I bring to that therapeutic relationship. Whether the privilege is education or ability or health or whatever it might be, whatever narrative it might be, thinking about how those dynamics sort of interact and interplay with the person you're working with. How would it feel to work with me as a mum, as a, Afro-Caribbean psychologist, always thinking about those dynamics. But I think because I work privately, I don't so much have those questions, but more so when I was working in the NHS or when I work in the charity sector, it's probably more acute there.
It's interesting because, you highlighted, we know that you won an award for being the first Black clinical psychologist. And, implicit in that is a kind of the idea that actually there's a bit more of a challenge there to having achieved it.
Yeah, I think that's why I struggle with the idea of privilege sometimes, because I know that it was very difficult for me to even train. Back in the 90s, I was one of 2 Black children in the whole school. And then on my course, I was probably for maybe 5 years, the only Black student in clinical psychology training. I think it's important to reflect on privileges, but I've definitely, and I talked about health earlier, I've had a lot of health struggles as well. So I probably feel like I walk the tightrope with my clients more so than on the privilege side. That, all these sort of intersections that I've had to navigate, I identify as someone who has a disability. I've got a chronic kidney condition. I'm a mum. I'm from a minority background in this country. So I think I probably draw on more elements of my identity that resonates with my clients and my team and sort of less have. But then I think sometimes, with the fees that we charge in private practice, I definitely feel it there where someone will say, well, how can you charge, £120 or £180? Or some people don't live on that for a week or a month, so that definitely comes into play when we're thinking about fees. And so we do try and offer a range of fees in our practice, and we have trainees as well so that we can meet the needs of a wide range of people with different funding and different budgets, and try and make our practices as accessible as possible, even though it is a private practice, really try and accommodate as many people as we can from different backgrounds. And that's why we're the diverse practice, I would say.
What kind of clients do you specialise in working with, Esther?
Well, it's interesting because I always said when I worked in the NHS, I felt quite pigeonholed in working with older adults, which I love. But I ended up doing neuro psychological assessments for dementia, and that's all I ended up doing. And so I swore that when I started private practice, I would be super broad and I'd work across the lifespan, as my company's called, Lifespan Psychology. And I wouldn't have a specialism and I wouldn't specialise. I work with all ages, all stages and all backgrounds, and that's our slogan. But I would say that trauma is probably that post-traumatic growth, and working with trauma is the thread that runs through most of the clients that we work with, and what underlies a lot of mental health conditions that we see and work with. And so I would like to think that I specialise in working with people from diverse backgrounds who've experienced trauma. But we certainly, work with depression, OCD, issues of self-esteem, stress at work. I do a lot of coaching around work and business, and I diversify what I do because I don't want to just stick to a niche. So I think we do so many things that we have a lot to offer. Mm-hmm. We're a team of 16 now, so we have a lot to offer. So anybody listening, we've probably got a match for you for something that you're going through at the moment.
And have you built that practice up yourself?
I have.
Wow, that's really impressive.
Yeah, so this is where BOSS comes in, the Business Owner Support Squad. So back in 2019, I got my kidney diagnosis, and I didn't have anyone really to help me. No one, you don't learn during clinical training, you don't learn how to set up a business. And then you don't learn how to be sick and have 3 kids either. Like, no one teaches you that. And so I sort of muddled through making up as I went along, and somehow found, this post-traumatic growth of having an incredible team alongside me now, where I can enjoy better health as well now, because I've spent a lot of time learning about my health and studying it and trialing things through trial and error a lot of the time, but nutrition and other things that I've used over the years. But I did start it from scratch, and it was just me. Then I got sick and didn't know what to do with my referrals, and then here we are, sort of 6 years later.
It sounds like a very large clinic. And are there particular, so you don't specialise in particular, apart from trauma, you try not to get into a niche, but I wondered what therapeutic models appeal to you. What models do you find yourself drawing on most?
So I am trained in cognitive behavioural therapy, but I lean a lot towards systemic approaches and systemic therapy, because I believe that the context, the system, the family, the network, the workplace, and everything that's going on outside the person's mind probably has a lot to do with what's going on in their mind as well. So I think that's my passion. I think my head is CBT and my heart is systemic. And then I do a lot of other therapies as well, but that's solution focused, narrative, acceptance commitment therapy, cognitive rehab, and our team do movement deprocessing, EMDR, lots of other therapies as well, sensory motor psychotherapy, motivational interviewing, you name it, we probably do it. Yeah, EMDR, stumbled across my words there, didn't I? Eye movement desensitization and reprocessing. It's a mouthful, isn't it?
It absolutely is.
Esther, this is a fascinating conversation. Can I ask you a bit about Oxford, and just to give you some context? So I'm in
Yeah.
Oxford. I live in Oxford.
Oh, wow.
And I did for a while work with the counselling service for the university. So, and I'll say a bit about that later if you like. But I was just wondering what your experience was like.
At Oxford, I absolutely loved it. It was just so
Did you?
idyllic. It was a place where I was fully myself because my whole life I felt I was underestimated. Esther, that's quite funny, isn't it? They underestimated Esther. So my teachers never really predicted high grades, and then I would get like all A stars pretty much from my GCSEs and then my A levels as well. And I was the only one of two black children in the school, and I was from a single parent background. So when I went to Oxford, it was the first time I wasn't underestimated, and it was just the most amazing feeling. I felt like I could do anything, and I really thrived, and I just love it. I love it there. I miss it. I miss it so much.
Yeah. So you found that people expected a lot of you then?
Yeah, definitely. Yeah.
And that was a pleasure for you.
It was just so wonderful because no one had really expected, apart from my parents who were amazing, they really believed in me. They always saw my potential. They always pushed me. My teachers rarely did. And so I had to live with that kind of the assumption that I wasn't from the background that would do well. And when everyone had laptops, I handwrote my essays still. So, I was, that demographic. So it was tricky, but Oxford was absolutely amazing and I miss it.
Well, that's fascinating. That's a real feel-good story. Thanks for that. I mean, I was interested because in the time, it was only 2 years, I think, that I worked for the counselling service. I don't think I saw anybody from a black or ethnic minority background. So minority groups who we were in contact with were people who came from Newcastle, and
I love it.
they found it really difficult because they felt outcast, because of their accents.
But it goes to show, doesn't it? It goes to show what an accent can do. Like, that says it all, really. That it's so subtle, like, culturally, and the intersections and the lived experience is so subtle, and you really have to listen in on that. But yeah, that goes to show how little diversity there was, I suppose, from your experience of counselling services in Oxford at the time.
Our view of it, yes. That is a very small sample I'm talking about.
Yeah,
you can't extrapolate very much from that. Do you think that podcasts have anything to contribute towards our own professional learning?
Yeah, I think personal and professional, definitely. I think this is a really interesting question because we need to understand where information is coming from and who's giving the information. There's a lot of misinformation out there. But I certainly think you can listen to some incredible podcasts and learn so much but you have to be careful who your sources are and what you're taking from that. They're not obviously there to give you medical advice or psychological advice or any advice. It's just really good to listen in on a really interesting conversation and maybe do a bit of sort of guided self-help or exploration or kind of get someone involved, mentoring or professional lens on what it is you're digesting from podcasts.
What podcasts do you like to listen to, Esther?
Well, the one that saved me, I'm sure Nikki Lowe will be really happy to hear me. She's an executive coach. But back when I was really, really sick, I was listening to Wisdom for Working Mums. So I'm going to give her a shout out because I think she was, listening to her from my hospital bed thinking, I may never be a psychologist again. Like, I may be on dialysis. And I had some coaching with her as well, and she was brilliant. So, yeah, and there was guests on her show, and that's the thing about podcasts. The guests that come on the show can just be so knowledgeable and have so much to share and bring. And there was a functional medicine practitioner on her show, and that's the person I've been using ever since. And I've just enjoyed better and better health, like, ever since. And I'm not on dialysis. So I think there are a lot of resources out there, and that was one. And then I really liked the Love and Abuse podcast. I thought it was amazing. Again, these so maybe like pop culture stuff a bit more, the Love and Abuse one, and it was someone talking from their lived experience. So they weren't saying that they were a professional or a psychiatrist or a psychologist or anything, but it was just him using his lived experience in such a powerful way to support others who would like read into the show. That he'd read their email on the show and then kind of troubleshoot and brainstorm and kind of give ideas and advice, but not obviously advice that would replace a medical doctor or anyone professional. But it still really helped people. I'm not sure how big his following is, but it's a love and abuse podcast with Paul Calioni. Those are my two favourites. But now my one is my favourite.
Good, thank you. Naomi.
Sorry. How do you look after your own well-being whilst working with people with very painful stories, Esther?
I think it's quite important to have your own personal therapy when you're in this profession. In any helping profession, really, I would recommend it. And we saw how important the staff wellbeing hubs were for the NHS staff during the pandemic. We all need to ideally have our own outlet or therapist or mentor or someone we can talk to. I really enjoy water, so anything to do with swimming and spas and I think that's how I always carve out time. Because I'm my own boss, I can carve out my week, so make sure I swim and do a bit of exercise and take care of my health and nutrition and try and cook fresh food and all those things, very much sort of looking at Maslow's hierarchy and making sure that your foundations are all there before you try and help other people. And I think it's really important that you do take care of yourself, or otherwise you can't really help other people optimally.
Brilliant. Thank you very much, Esther.
So, Esther, can you tell us about the post-traumatic growth inventory?
Yeah, I was really excited to stumble across it because we tend, like I was saying, we tend to measure like deficits in mental health or when things are going wrong, when people are struggling. And this is a really beautiful tool that looks at post-traumatic growth areas. And it's not your usual quantitative where you give someone sort of a score that means, oh, you know, you're doing really badly or, oh, you're doing really well. It's not really like that. It's a qualitative tool. And
how about so you give us a 20-second explanation of post-traumatic growth?
Sure. So this particular scale, it covers 5 areas, which I think are really helpful to look at. Appreciation for life, spiritual growth, personal strength, new possibilities and improved relationships. And so every question on this questionnaire basically is looking at to what extent they feel that as a result of their crisis or their trauma, they've experienced growth in particular areas. So, you know, I've changed my priorities about what's important in life, or I've greater appreciation or value for my own life, or I've developed new interests or new community, or I can count new people that I can count on in my life, or I have a greater feeling of self-reliance, or I can handle difficulties now and I can do better things and greater things with my life. So even stronger religious faith. So somebody on our podcast, it was great to have 2 men who'd recovered from addictions on the podcast, and they'd both been to addictions groups, support groups as part of the AA inpatient treatment. And just the spiritual growth that they encountered after they'd had therapy and after they'd been treated for PTSD, and like a much greater and deeper connection with God than you'd even ever imagine. One of them was a journalist and had seen 5,000 bodies killed during the tsunami. And yet he, you know, several years later through therapy can rediscover a connection with God where he's not angry. And then he's bringing that to talk to the community about how God has come into his life and changed his life, and how God's in the driver's seat, and how that's helped him recover from his addiction. So I think this is a really interesting tool that I'd be wanting to use more in my work, the post-traumatic growth inventory.
Right.
You were talking about the journalist and him rediscovering God, and talking about how it would be good to use this inventory more in our personal practice, which I agree with you.
Yeah. And I was just saying it's the opposite of feeling suicidal. It's the opposite of wanting to take your own life. And how do we turn someone's life from completely hopeless, not wanting to be here, to having a really fulfilling life of meaning, you know, building a community and hope and a sense of value and purpose. And so I think it's just really wonderful to sort of work on, flipping that, turning that on its head. So the post-traumatic growth inventory is by, and I'm not going to pronounce them incorrectly, so I'll send you the link, Tedeschi and Calhoun, 1996. Tedeschi and Calhoun, I think.
Great. Good. Well, put a little description of that or a link or something.
Yeah, sure.
In the show notes too.
Yeah, sure.
Good.
I'll be Googling that myself. It sounds really interesting as a tool.
Yeah.
And actually a much nicer way to evaluate treatment at the end, I think.
Yeah, absolutely.